Hey, Scott again here. Today we're focused on cardiac stuff. We'll start with the parasternal views. Again, shout out to thepocusatlas.com for a lot of images and GIFs. We'll start with the parasternal long axis view. The long axis view, we are next to the sternum in kind of the pulmonic and tricuspid listening post areas. You're going to start just below the clavicle, next to the sternum in that intercostal space, be the second one, and then just move down rib space by rib space until you start to see cardiac motion. It's a long axis view because you're cutting from the base of the heart all the way down to the apex. You're not going to see the apex of the heart. Generally, you just see the left ventricle sort of carry off the screen. And let's take a look at what a normal view is going to look like. So up at the top of the screen, we've got the right ventricular outflow, the RV just before the pulmonary arteries. Next, we're going to see aorta back here and that left ventricular outflow, and then left atrium. Those three things are sort of stacked on top of each other. Over here to the left side, we're seeing the left ventricle, the interventricular septum there, and then pericardium is this nice bright structure here in the background. You'll also probably see descending thoracic aorta in our models. It's just below that left atrium. Sometimes it's kind of over here between the atria and ventricle. One important note on cardiac scanning is that the probe marker flips to the other side of the screen. So even though our probe marker is pointed at the patient's right shoulder, the right on the patient is over here on this side of the screen, and the left on the patient, right left ventricle, that's over here on this side of the screen. Right, so there's our cut. We got RVOT, the septum, LV, and then that aorta, LA, RVOT. Those are all stacked on top of each other. We're only seeing the anterior, or the anteroseptal wall and the infralateral wall of the LV. So we can make some claims about ejection fraction, but we're really only seeing two walls. You may have heard of inside out. I'm going to advocate for outside in interpretation. So we're going to take a look first for an effusion. So we're keeping our eyes down on that pericardial area, that pericardium, and then we're going to look at a rule of three, so comparing the size of right ventricular outflow, aorta, and left atrium. They should all be about the same size, and then we'll talk about a few ways to assess LV function in this view. So starting with effusion. This is a view of a parasternal long axis with a small effusion in the background. Again, we see that bright hyperechoic pericardium back here, and then this is that left ventricular free wall, and in between we see this anechoic signature. So that's a little bit of fluid sort of interposed in between the pericardium and that LV free wall. So that's indicative of an effusion there. If I moused into it, then maybe a giant red arrow will. Here we have evidence of a bigger effusion. So again, we're down here in this area on the back side of the LV free wall and just proximal to that pericardium. Here you can see the descending thoracic aorta. Sometimes it'll be confusing if it's a pericardial effusion or a pleural effusion. Usually the descending thoracic aorta can help guide you. If that fluid is on the back side of the descending thoracic aorta, that's pleural, right? It's outside of that mediastinal window there. And then if it's interposed in between the thoracic aorta and the heart or that LV free wall, then that's likely a pericardial effusion. So there's our big effusion. And you can see a little bit of actual RV diastolic free wall collapse. So that would be indicative of tamponade physiology, right? The diastole is that lowest pressure part of the cardiac cycle. So if you have enough pressure built up outside of the heart that the RV free wall is collapsing and not filling fully, then you can wind up with tamponade. So here's an example that you saw from the ultrasound basics lecture when we talked about M mode. And this is a demonstration of tamponade physiology. So again, we've got the RV free wall up there, and then the septum and the mitral valve leaflet. And what we're looking at is when that mitral valve is swinging open, that cues the beginning of diastole. And at the same time, we're seeing that RV free wall collapse towards the septum. So in that low pressure part of the cycle, the RV is collapsing and not filling appropriately. Our rule of three, so we're taking a look at left atrium, the RVOT, and the aorta. We're comparing each of them. They should all be about the same size. There's a little bit of wiggle room there, but oftentimes if one is much larger than the others, that indicates something pathologic. Yeah, so here we've got our three lines, and when we compare them all, we can see that the left atrium is pretty enlarged and that the RVOT actually is a little bit big too. So if our aorta is the benchmark, then both of those are a little bit big. And then you're sort of tying that to the clinical picture to understand why that is. Here, I'll let you just look at the image for a few cycles and try to determine which of those chambers is big. Probably not too hard to figure out. So our aorta is ginormous. This was an aneurysm and had progressed into a dissection of the ascending thoracic aorta. So there's your aorta, super wide relative to the RV and LA. Another example here. All right, so we got RVOT. This is aorta. This is left atrium. When we look at our lines, our RV is enlarged. So this was an example, I think, of pulmonary hypertension. Somebody with chronically elevated right-sided pressures. The RV then sometimes it hypertrophies and then it begins to dilate. Dilation usually is sort of an acute change that it undertakes because it's kind of a capacitance chamber, and then it can begin to hypertrophy, and over time when it fails, it just balloons out. Left ventricular function, we use a few different measures. One thing we look at is just how close to the walls come together. So that's called endomyocardial excursion, right? How close to those walls come with each squeeze. The other thing we look at is how thick the muscle becomes. So it should become like 30 to 50% thicker with each squeeze. Here in this example of pretty severe reduced left ventricular function, we see the septum not really squeezing too much. Same with that LV free wall. And you're not seeing those walls come together hardly at all. So not a lot of squeeze. This is a severely reduced EF. We try to divide with POCUS into large buckets. So we're not really giving an exact percentage estimate of the EF. We're just trying to determine whether it's significantly reduced to contribute to the clinical picture or not. And it's a little bit more difficult to tell in kind of that fuzzy middle area, but in a heart like this, you can probably say with confidence this is severely reduced. Here's a more difficult example. So this was a patient I actually saw on the wards who was having increasing respiratory distress and getting a lot of lung shadowing with this parasternal view. Kind of tough to tell. I mean, it looks like maybe the squeeze is decent. So one other method of assessing left ventricular function you can do is it's called the EPSS, or E-point septal separation. And what we're looking at here is dropping that M-mode line where that anterior mitral valve leaflet is. And what we want to see is how close that leaflet comes to the septum each time it swings open and diastole. If it's coming within 7 millimeters, so less than a centimeter, then that's indicative typically of a normal EF. If it's greater than that, and my kind of loose cutoff to improve specificity is 1 centimeter. If it's more than that, then that typically indicates you have reduced function. So in this case, it was around 1 to 1.1 centimeters. This patient did have a formal echo that indicated an EF of around 45 to 50%. So E-point septal separation, or EPSS. So again, our EPSS, 7 millimeters is a cutoff that gets used a lot. This was developed from emergency department patients, and then I expand that a little bit to 10 millimeters when I'm doing a bedside assessment just to improve the specificity. And then the other method that we can use is just assessing the thickening and shortening, right? And then taking a look at that mitral motion. As the LV squeezes, we should also see that mitral valve travel towards the apex a little bit. In a study that was performed more than 10 years ago now, they gave residents, internal medicine residents who were second and third years, little portable units that aren't as nice as the ones that you'll have access to. and just had them do parasternal views after doing a little bit of training, and they were able to recognize severely reduced, so ejection fraction less than 40 or greater than 40 in the majority of patients. In that study, there was a high prevalence of heart failure, and so they were it was maybe a little bit easier, sort of like fishing in a barrel, but these are relatively reliable markers of reduced ejection fraction. And once you have a few cardiac scans under your belt, you'll be able to recognize these, especially when it's severely reduced. A couple of caveats: if you have a sclerotic mitral valve, like from rheumatic heart disease, then the mitral valve is not going to swing open, even if the EF is normal. And then if you have aortic insufficiency, so a regurgitant jet of fluid coming back through the aorta, it's not going to allow that anterior leaflet to open quite as fully, right? So there's like water pressing on it or blood pressing on it as it tries to open. So those are two situations when this is going to be an unreliable marker, that EPSS. Again, just to reemphasize, we can tell pretty well if something is severely reduced or normal, but it's a little bit harder in that area in between, like between 35 and 50% on point of care exams until you've done quite a few, right? So it's easy to tell between normal and way reduced and camel. But if you're trying to differentiate between a black and a white rhino, it's a little bit tougher. So that's when I would lean on your measurements and also depend on probably formal echocardiography until you get really good at it. I am not sure which of these is black and which is white, but you can check out wildlifewoods.net/blog/whatever to find the answer. Our parasternal short axis view is in the exact same spot, but we're just going to rotate the probe 90 degrees. So we were pointed, here's our probe marker at the patient's right shoulder, and now we're just going to rotate 90 to the other shoulder. So same rib space. Sometimes you will have to move down a rib space or kind of down within that same rib space. Other times you'll have to fan towards the apex. So we're moving that beam closer to where the apex is because we want to get a mid-ventricular cut. We want to see what's going on in the middle of that ventricle. We know we're in the mid-ventricle when we can see the papillary muscles. They'll look like two little boxing gloves that are protruding from the ventricular wall. So here's a view of a parasternal short axis. We've got a nice round LV, donut shaped, and then our RV is sort of over here at the between like 9 and 12 o'clock position, and it's shaped a little bit more like a croissant, a little parasite on top of the LV. What we're looking for here is good endomyocardial excursion, right? Do the walls come together nicely? Does the muscle thicken well, that myocardial thickening? And then we're also looking for preservation of this septal curve. So we want to make sure that pressure distribution is good and normal, that the LV is the highest pressure system all throughout the cardiac cycle. When that septum bows in or it's flat throughout the cardiac cycle, that could be an indication of high right-sided pressures. You can also oftentimes see a pleural effusion or a pericardial effusion back here behind the LV. So there's our LV and RV. The advantage of this view is that you can see all the walls at the same time. So with our parasternal long axis view, we only saw that anteroseptal and infralateral wall. But with parasternal short axis, right, you're getting a look at all of them. And that's something that you can correlate with your EKG. If you have an abnormal finding in one coronary artery distribution, you can take a look for regional wall motion abnormalities that fit that distribution on the ECG. So how can we appreciate ejection fraction? Where we talked about endomyocardial shortening, right? How close do those walls come together with each squeeze? And also our myocardial thickening. So how thick does it get each time it squeezes? The chamber size should decrease by about 30 to 50%. That's your shortening. And then it should thicken by about that much too, by about 50%. Here's an example of a grossly abnormal heart. It's not so much squeezing really in a coordinated fashion as undulating. So this was a patient with sepsis and pretty severe acidosis. Acidosis impairs that myocardial action, and you wind up with reduced EF. Here's a really low EF also. Here we're just a little bit above the papillary muscles. Notice that they look like crab claws. That's where the chordae insert into the papillary muscles. So if you're up at those crab claws, you can try fanning down towards the apex a little further. So we're going to fan down towards the apex of that motion. And we're looking for our endomyocardial excursion. You see that the walls just barely cross that outline that I've drawn. Here, we've got a few things going on. So effusion here in the back, this is what a pericardial effusion is going to look like on a parasternal short axis. Just like with the long axis, you have that LV wall and then an anechoic signature here, and then your pericardium in the background. Notice the septum is bowing quite a bit. So this is indicative of high right-sided pressures, and the RV is actually like huge, ginormous. It has completely sort of outgrown that space that it usually occupies between 9 and 12 o'clock, and our LV is feeling the strain. So there's our effusion. We've got bowing of that septum, and then the RV is ginormous. Here again, we've got that septal bowing, and then the RV looks enlarged. Right, so this could be a sign of something acute, like a pulmonary embolism. It could also sometimes be chronic, something like pulmonary hypertension. Yeah, I think that's it. So go ahead and scan, try to get parasternal long and short axis views. Use M mode and try to calculate a plaque's EPSS, and then try fanning up and down through that short axis view. You'll be able to fan up towards the base of the heart, see the aorta, the tricuspid valve, right and left atria, sometimes the pulmonic valve, and then fan down towards the apex, even past the papillary muscles sometimes.